Good morning to all. We appreciate that after the nightly event yesterday that you are up to join with us for a conversation for this panel discussion on the health impact of war and terror and how the aid for that can be coordinated. This panel is hosted by the M8 Alliance and the International Committee of the Red Cross. So, as you all realize, as you read or hear the headlines, unfortunately, we are not in a time of peace. There is war and terror on different locations on the earth. And although our global health community may have limited power to curb all these aggressions, we can provide timely and credible information on the expected and actual health consequences of these conflicts. We can also help in treating injuries and disease during and after war and terror. So this is how we will work this panel discussion this morning. We have 5 fantastic guests for you. Each one will speak for about 8 or 9 minutes, no more, I hope. So we can have a conversation with you, the audience, and also with the speakers amongst themselves. So let us start with Mrs. Christine Beerli, who has a long political career in Switzerland. She is a lawyer by training, and currently she is Vice President of the International Committee of the Red Cross. So please welcome Mrs. Beerli.
Thank you very much, Madam Chair. Ladies and gentlemen, thank you very much also for giving the International Committee of the Red Cross the opportunity to speak here about the impacts of war on health from an ICRC perspective. The ICRC being a frontline organization for more than 100 years, we are working in war zones around the world and we really experience what is happening. While many of these conflicts are getting very protracted, the 10 most important operations of the ICRC, we have just once looked how long we were staying in this context. And we have seen that in average we are staying more than 30 years in these big protracted conflict contexts. And in this sense I would like to highlight 3 aspects how war can impact health in these protracted conflicts. First, we have interruption of the supply chain. I would just like to say a few words about this. Then the challenge of providing continuity of care as patients flee the hostilities. And then also a third point, which is the challenge of access. These 3 key factors illustrate how local disruptions of healthcare in conflict settings can impact regional and global public health, and how decisions also and frameworks at the international level could affect our capacity to address health emergencies within war zones and to contain the risk of them spiraling out of control. Without doubt, conflict has a massive impact on the health of civilian population. In Yemen, for instance, 14 million people lack access to adequate health care. A mere 45% of the healthcare facilities continue to function. However, the reason for the stress put on healthcare systems in areas of conflict is not always a direct consequence of the hostility. Conflict also disrupts national, regional and international supply chains, which has a direct impact on the ability of humanitarian and local health actors to respond. In addition, more stringent regulatory and/or monitoring frameworks, for instance, in the light of international health regulations, may have the unintended consequences of increasing the complexity of processes and prevent efficient delivery of humanitarian assistance in situations of crisis. Typical examples are delays in processing shipments or issuing necessary permits to transport supplies and access areas in need. The consequences of collapsing healthcare systems beyond immediate care for those wounded or impaired by the conflict are threefold. High mortality rates from treatable diseases such as malaria or respiratory conditions in children, or indeed obstetric complications for women. In some areas of Syria, women prefer to schedule cesarean or give birth at home rather than risk being in hospitals when they come under attack. Epidemics become significantly more difficult to contain. We are most alarmed by the recent cholera outbreak in Yemen, which has spread like wildfire, just recently surpassing 800,000 cases, with up to 1 million cases expected by the end of the year. It is also worth noting that the fight to eradicate polio is now largely limited to places affected by conflict. New cases are appearing in Syria and Afghanistan. Finally, intermittent partial or incomplete treatment of communicable diseases such as tuberculosis not only prevent recovery, but can also favor the emergence and spread of multi-drug resistance. It is not difficult to see the importance that being able to manage such diseases in conflict settings has also for regional and global public health. Disease containment is difficult under the best of circumstances. When conflict-affected populations are forced to move, the effects are amplified, which brings me to my second point, to continuity of care. Armed conflict generates displacement and refugee flows within countries at war, but also across borders and continents. Increasingly, the ICRC and other humanitarian actors are confronted with health needs that do not directly relate to battle injuries. Instead, we are dealing with consequences of partial, discontinued or non-treatment of non-communicable diseases like diabetes and cardiovascular conditions. For example, in certain contexts like Myanmar or Iraq, our physical rehabilitation centers are reporting more amputations for untreated diabetes as opposed to war injuries. Another aspect which is often hidden or difficult to measure amidst a crisis is the impact of war on the mental health and psychosocial status of individuals. Post-traumatic stress disorder, grief, depression, and many other conditions are often undetected and left untreated in an environment where specialized services are lacking or referral pathways are broken. Access remains one of the main difficulties for health in and around conflict environment. This includes not just the availability of health services and medical supplies, but also the ability of healthcare personnel to access patients, to safeguard their rights, and to provide care without becoming victims themselves, as well as the ability of patients to access healthcare without discrimination or fear for their safety. From 2012 to 2014, over a period of 3 years, the ICRC documented almost 2,400 incidents of violence against healthcare across 11 countries. These incidents involved both state armed forces as well as non-state armed actors. Unfortunately, this trend has not come to a halt, in spite of the provisions of international humanitarian law and the adoption of UN Resolution 2286 on the protection of civilians in armed conflict. Whether in Syria, Yemen, and Iraq or Afghanistan, South Sudan, the Central African Republic, and Somalia, we continue to be confronted with the use of explosive weapons close to hospitals or even targeting hospitals. Recently, there have been 10 attacks on 10 hospitals in the Syrian governorate of Idlib and Hama. Armed actors occupying or looting health facilities, patients being discriminated against or indeed being detained at hospitals before receiving emergency assistance, delays for ambulances at checkpoints that can be decisive for a patient's chance of recovery and survival, attacks targeting healthcare transport and threats against healthcare personnel. Just to give you an idea of the scale, 598 healthcare workers were killed or beaten and wounded in the 3 years survey alone. When healthcare is not respected and protected in armed conflict, when healthcare facilities are destroyed and health workers are attacked, civilians wounded and sick pay the human cost. When communities already enduring armed conflict are exposed to health crises, they succumb to completely man-made catastrophes. When essential health services are unable to cope, health-related sustainable development goals become impossible to achieve. In order to assist those in need and to prevent and contain health challenges, there is a clear need to enforce compliance with international humanitarian law and to safeguard the space for principled humanitarian action. However, humanitarian actors alone cannot carry out these tasks. In order to support health systems and communities affected by war and armed conflict, multi-stakeholder engagement is not only essential, it is an absolute imperative. Thank you very much.
Thank you. Microphone? Yeah. Thank you, Madame Beerli. And now, please welcome Dr. Matshidiso Rebecca Moeti. She has 35 years of experience with public health priorities, and she's also the first women regional director for Africa for WHO. Dr. Moeti.
Thank you very much, Hélène. Ladies and gentlemen, dear colleagues, I think we've had an excellent overview and introduction to this topic today, and we are just reminded by the tragedy that just occurred in Somalia, in Mogadishu, where a bomb has killed over 300 people in the city, and this is thought to be the worst, among the worst of the attacks in that city and in that country. So we are living in a period where every day, every week, every month, we do indeed see the manifestation of the impact of war and terror on the health of people. For example, the Boko Haram insurgency in Nigeria and in the Lake Chad Basin has affected about 17 million people. And I will be talking to you later on about some of the health impacts and the challenges that are presented by this situation, which has lasted over a number of years in ensuring that the health of the population continues to improve. I won't say much about the way in which humanitarian law is being flouted through attacks on healthcare workers and health infrastructure. The Geneva Convention, we've already been told, prohibits such attacks on healthcare facilities, but we are seeing more and more of such attacks occurring, unfortunately. So the impact of war and terrorism on the health of people is massive, not only on the health of the targeted populations or the populations that are immediately in the vicinity and are affected, but also on global health security. We live now in an interconnected world, and if we're not able to prevent outbreaks of communicable diseases, to immunize children and people as is necessary, we run the risk of such diseases spreading internationally. For example, in in northeastern Nigeria, in Borno State, we had wild polio virus transmission confirmed in 2015, and we have had to WHO, the governments of four additional countries, that Nigeria, Niger, Chad, Cameroon, and the Central African Republic, have had to invest a lot of effort in improving their surveillance, implementing preventive campaigns against polio, and thus ensuring that they are containing a possible outbreak and international spread of polio in a region where not long before that we had celebrated having Nigeria declared no longer among the endemic countries for polio. We've had to work with these countries to declare the outbreak a regional emergency, and we've had to work with them in order for them to be distracted from providing other health care, to invest in recurrent and repeated synchronous polio preventive campaigns. War and terrorism also reduce or deny access to curative health services for people. In South Sudan, over half the population lacks access to functional health facilities, and it's already been outlined because of problems with the supply chains. There are frequent stockouts of essential medicines and other commodities that are needed for both preventive and curative service delivery. In the Central African Republic, where I visited in June, nearly a quarter of the health facilities are totally or partially destroyed. Only half of the laboratories, only 10% of the blood banks, and 20% of antiretroviral therapy services are functional. And the Central African Republic has one of the highest prevalence of HIV in the Central African sub-region. Many partners have been forced again recently to withdraw from the most dangerous regions where it seemed that their staff and their facilities were being particularly targeted for attack. And in order to protect the lives of their staff, have had to simply withdraw some of the services that were being provided to this population, which is already at such a disadvantage. I've also just come from a visit to northeastern Nigeria, where the health of people and healthcare delivery has been directly affected by the insurgency, as I said before. In 2016, nearly 2/3 of the 743 health facilities in Borno State were completely destroyed or damaged. Many people, mainly children there, have not had access to routine immunization services. As we know, access to the population has until relatively recently been impossible. And up to now, 6 local government areas or districts are still completely inaccessible to humanitarian partners and indeed to the government system. Some 3.7 million people, nearly 60% of whom are children, are at risk of malaria, which has caused many deaths. It is the first cause of illness and death among children in northeastern Nigeria. There have also been outbreaks of cholera, and we have supported the government to respond to a recent cholera outbreak, which had more than 4,000 suspected cases and 60 people died. Measles outbreaks, outbreaks of hepatitis E, mainly due to the fact that it's impossible to provide preventive services, including vector control in these areas. And it is also very difficult to conduct surveillance and to be able to know quickly when an outbreak is about to start. And the same is the situation in Niger, where in the eastern part of the country, I visited DIFA in June in Niger as well, and the similar problems and difficulties in providing preventive services and curative care to the population exist. Freedom of movement is severely curtailed. So referring patients who need more specialized care from these IDP camps and villages is impossible. So people have had to be not able to have surgical services, including cesarean sections. I believe one of our colleagues is going to speak more in detail about the impact on maternal mortality of these situations. The impact on healthcare workers has already been mentioned. They are under enormous pressure and they are at risk and they get killed when attacks are carried out. And I think that I've seen in visiting our country teams and in interacting with some of the healthcare workers in these risk areas, how profound are the psychological, the social, the financial, and indeed on their families' impacts on these people who are brave enough to be trying to provide health services to the populations under these very difficult circumstances. It's impossible for these healthcare workers to have training of any sort. Some of the institutions in these areas have had to close down, thus exacerbating, at least in the African case, the already existing crisis in human resources for health. We also see difficulties in providing clean water and sanitation in the crowded refugee and internally displaced people's camps that have had to be put up in some of these situations, and the risk of communicable diseases, for example, cholera, is very much increased. Nutrition is also, malnutrition is also exacerbated in these areas. Agricultural production declines in these conflict situations. The production of food is therefore a problem, and people need not only health care but also nutritional services, including treatment of severe malnutrition among children. And in South Sudan, for example, about 6 million people are at emergency or crisis level in terms of food insecurity. In Borno State in Nigeria, acute malnutrition from food insecurity is also rapidly rising. We've learned from many humanitarian crises, including the Ebola outbreak, which was not related to conflict, but was a severe humanitarian crisis in West Africa, that coordinating the response and coordinating aid is absolutely critical in these emergencies and is important in order to avoid fragmentation, to reduce duplication, and to make the best use of the resources and the capacities that are availed to support the local populations and governments in responding to these crises. But we recognize that despite some improvements, which I will talk about as far as the health actors are concerned, significant coordination gaps still exist, and this is an area of the work that requires effort from many of us. We observe that many players, many actors, all intending and wishing to provide support and make their contribution, can act sometimes in fragmentation and in ways that ultimately compromise the outcomes that we're all trying to achieve. In some countries or in some situations, the government's capacity to lead and to coordinate is compromised, or the capacity may be poor. And of course, we realize that in some areas, the government itself may be involved in the conflict, which further exacerbates the difficulties of coordinating the humanitarian response. But it is something in which we need all to put our efforts. And I'd just like to say that proper aid coordination in these contexts usually requires predictable leadership. It leads to improved effectiveness of the humanitarian response, and it both depends on and produces enhanced partnerships, and of course requires increased accountability from all those who are committing to contribute to improving the health of people in this difficult situation. It works best if there are attempts at jointly planning what is going to be done, knowing who is responsible for providing what support, why, how, where, and when, and also establishing mechanisms for jointly monitoring what is happening and ensuring that all the actors deliver what they have promised to deliver, and there is a high level of accountability. There is also a need to ensure that humanitarian aids contribute to building resilience in these communities and these countries, and as far as health services is concerned, hopefully leaves more sustainable health services than was found. It requires inclusive, equal partnerships, building trust among all of those who work in supporting communities and providing services. And it is stronger if pre-existing relationships among the different actors already are in place. We have seen examples. I'd just like to give some examples of how WHO has worked with the health clusters in a number of crises in order to foster and improve the coordination. And really just saying that our intention is to be a good partner, a good health cluster coordinator, do our part in delivering what WHO is supposed to do, but help in mobilizing the resources and the capacities needed for the entire spectrum of health actors to be able to play their part. As I've said, this is an area of continuing challenge, but I'm pleased to say that we are starting to see some improvements in some of the situations that we are facing. For example, in the Central African Republic, the WHO office, under the leadership of our WHO representative, has managed to work to support the government to develop a transitional plan for health and to rally around and coordinate the different health actors to define how they will contribute to this. And this has required really providing a forum, a venue for the health clusters to meet, and a regular mechanism for reviewing how everyone is contributing to this process. It's not always easy. We've seen some improvement also in this northeastern Nigeria insurgency humanitarian response, in which we are supporting the government to provide basic health services as well as respond to a number of outbreaks, including malaria outbreak and cholera outbreaks. We have established emergency operations centers in Borno State, at which all the partners who work on health have some space to work together, and we are coordinating the actions of 22 health sector partners in these very difficult situations, all of us working to support about 90 health facilities to provide basic health care to people and facilitating care to over 3 million people this year in this area. And this requires, I believe, building the kind of trusting relationship where all of us demonstrate that when we commit to doing something, we are accountable for what we promise to deliver, and we carry out joint reviews and assessments of how our collective work is going. We've established sub-field offices in the Central African Republic, which again provide the opportunity for some of the other partners to have a base, and we also put some of our staff in the premises of other partners so that we have a coordination mechanism that works at the central level in the capital and also in the field where we are supporting the provision of health services. I have to say that one of the most challenging areas in which to have a coordinated approach is in mobilizing resources and accounting to donors for the money that is given, because we have a tension sometimes between working in relation to the priorities defined with the donor and adjusting what we do in relation to the context and the needs of the population as the situation evolves. But I believe that much effort is going on, at least in some of the examples that I've seen in South Sudan, in Central African Republic, in northern Nigeria, to improve this coordination, which ultimately ensures that the resources that are available go a longer way, are more effectively used, and we collectively help the governments and, most importantly, the communities, the population, to have better health outcomes than if we had been working separately. So I do recommend that this is something that we all need to continue to work to improve, respecting the principles that have been defined for coordination in humanitarian action. Thank you very much, Madam.
Thank you, Dr. Moeti, for setting the stage for a discussion later on about coordinating aid and coordinating donation for aid. As we all know, even in non-war situations, women and children are, in our world, the most vulnerable people. So you can imagine in a war and terror situation how that can be. So the next two speakers will be discussing maternal and child situation. And let us begin with Mr. Tewodros Melesse, who has 30 years experience with organizations that attend to sexual and reproductive women's health. He is from the International Planned Parenthood Federation, where he is the DG, the Director General. Mr. Melesse, please welcome him to the podium.
Thank you. Good morning. And it's really a great pleasure to be able to speak at this World Health Summit. for IPPF, it's really important that sexual and reproductive health are addressed in all situations, because sexual and reproductive health happens in all parts of the world, in conflict, without conflict, in peace, in disaster. And it's really important today, when the world lives alone in the crisis situation and conflict, but also in other parts of the world, when it's becoming like a taboo of speaking about sexual and reproductive health. It's becoming controversial. We live in the time of denial, where the products of not fabrication, not product, but were results of sexuality. But unfortunately, the world is in denial, and the whole movement, sexual and reproductive health, is put in danger in many parts of the world. Well, as you know, we are witnessing the highest levels of displacement and in conflict situations today. There is an unprecedented number of natural disasters and conflicts so significant that 20 people are displaced every minute. When you ask the majority of people what they think of when you say emergency, the response is, of course, security, shelter, food, and, housing, and so on, but never sexual reproductive health. But sexual reproductive health issues are leading cause of preventable diseases worldwide. And in many ways, the experience of inequality during stability becomes highlighted in situations of crisis. It is a silent killer. It's also a sensitive topic that people, based on their own values, rather than the clear statistics around the prevalence of rapes, maternal deaths, gender-based violence, not only in stable times, but especially higher in conflict situations. In fragile states and conflict situations, it's estimated that lifetime risk of maternal mortality is 1 in 54, whereas it is 1 in 180 in global lifetime risk. Delays in receiving care among the most significant factors in maternal deaths are happening in asylum seekers and conflict situations. Over 1/4 of people in need of human assistance are women and girls of reproductive age between 15 and 49. 1 in 5 women are likely to be pregnant during a humanitarian crisis. Sexual gender-based violence, it gets worse in humanitarian crisis situations. Displaced people's camps and temporary shelters are areas particularly dangerous for women and girls. Rape, sexual assault, gender-based violence are frequently encountered. HIV and STI transmission, this also takes place. Thus, we have to act in these conflict situations in providing the necessary support for those, which are in conflict situations. These standards, which are according to the worldwide agreement, be it the 1994 International Conference Population and Development, which took place in Cairo, the Sendai Framework for Disaster Risk Reduction, 2015 to 2030, the Sphere Project of Humanitarian Charter, all this recognize the need to interfere in humanitarian crisis for sexual and reproductive health. In IPPF, we have worked with other agencies, UNFPA, WHO, and UNHCR, to set up the minimum basic limited reproductive health essential services, which are called the MISP. They are called MISP, and they are part of the SPHERE project, the Standards for Disaster Response. This was developed in the 1990s, and it's being evaluated. In November, now we are going to have the revised and based on the evaluation, and it will be coming out a new minimum essential. The goal of the minimum essential service package is to reduce mortality, morbidity, and disability among populations affected by crisis, particularly women and girls. This includes a prepackaged kits of containing drugs and supplies and at facilitating the implementation of priority reproductive health services in the early phase of a crisis, like, containing condoms for areas where the HIV/AIDS prevalence is there, the ARV, and emergency pills, tablets, and sanitary naps and so on in situations of the crisis. I'm going to skip some of them. So this really, the help to identify the immediate situations, how to prevent and provide preventive services, transmission of STI, HIV, maternal and infant mortality, and also comprehensive sexuality education, because we have to provide in such kind of situation, young people who have never heard about that are also there, so there is a need to provide those essential services. For us, really integrating this in the humanitarian setting, working in partnership. We in the IPPF, we are working in over 170 countries across the globe, and we are not setting a humanitarian response team because our organization exists in times of peace and in times of crisis. So it is preparing these organizations to be ready to be responding to crisis rather than turning ourselves into an emergency response organization. And we have provided training. If you take countries like Pakistan, where the flood and so on has been affecting, we trained the government agencies, and now the Ministry of Defense, which is taking the lead in providing assistance in emergency situation, has included the minimum essential service package and reproductive health as a package to be responding in times of natural disasters. Our association is working in Syria, and both inside the country and outside the country. The working in the unwanted pregnancy and raise in STI, there is an increase in sexual harassment and exploitation. Early marriage is increasing significantly among the displaced population, so we have to be providing those essential services through our association. Over 3 million services have been provided just in 2 years' time, within and outside Syria, where the displaced population in Lebanon, Jordan, and also inside the country. This is a situation where we have a staff of about 650 volunteers, which are over 540, providing through mobile clinics and also status clinics in consultation both with the government and with the rebel-held areas. And for this, there are also the after abuse, where there is a crisis and they need to be provided with counseling services. Now, currently, as you know, Rohingya crisis is really a very serious crisis, which is among the displaced population which have come in Bangladesh. We are working with agencies which are working there, also our association. There is rape which is taking place, and gang rape so frequent among the young people. And how do you provide the essential services in case of pregnancy, both for safe delivery, but also, if necessary, for safe abortion services? That is an essential part of the package that we are doing. I know that in mobile setups and in displaced population where the health system is not working, it's a very difficult thing, but providing an essential training and getting the health workers trying to work with the other agencies for their own safety. The community supplies, which has been raised by the Red Cross, is a very serious one. The partnering, because some of our partners talking about sexual and reproductive health, not because they don't believe themselves, not because they don't see it, but for some quarters it becomes like a taboo. Today you see the US administration with a gag rule, what it is imposing, not to be talking about, even referring for sexual and reproductive health services, which includes abortion, not with the US money, but with even our own money. That is something we resist in such kind of conflict situations. With how many things are we going to be oppressing the displaced populations? Just think about it for a minute. In times of crisis, when you have, in addition to your own safety, the food, the necessary education, if young people are traumatized, raped, and coming to birth in such kind of disastrous situation, how are we going to be building peace? Will traumatized people be able to generate peace? Will people without hope, not being educated, not being fed, not being given the right information and support, do you expect them to return in times of peace with peace? Just think about it, and that's what we are saying. We cannot ignore this trauma if we really want to avoid the silent killer. We need to provide the essential services, not only to save lives of today, but to build into the peace of tomorrow. It is essential we address these essential services. Thank you.
Thank you, Mr. Melesse, for this excellent talk, which brings to mind if we can decrease by prevention the number of children who are now sort of called, a lost generation of children, and which leads to our next speaker, Mrs. Susanna Krüger, who is CEO from Save the Children Germany. She has several years of experience in developing cooperation in the Middle East, Asia, and Africa. So let's talk about the children now. Thank you. Please welcome Mrs. Krüger.
Distinguished guests, dear panel, thanks for inviting Save the Children. It's probably an organization that not everybody knows, but I will talk a bit about what we are doing for children and in health crisis. And I'd like to take the opportunity actually to shed light on a global health issue which we as Save the Children experience every day in our work. And it's the health crisis my colleague just spoke about. It's the mental health crisis that we see in children in countries of war, and what is going to happen to them if they left untreated. So I will proceed where my colleague just finished. For those of you who don't know Save the Children, we work in over 120 countries to protect the most vulnerable children in the world, particularly in countries where they are affected by ongoing conflict. And we work in education, in nutrition, in healthcare, and also give mental and emotional support, which I personally find one of the most important things that we are doing. And we also advocate for the rights and basic access to healthcare, and that's why it's good to speak to you as a healthcare community. Can you imagine that at this very moment, 250 million children live in regions affected by conflict all over the world? 250 million children. And what it means to these children's health. And if you recall what Ms. Beerli said in the beginning about access to health institutions, I can show you what it means for children not having access. It means they have no or only restricted access to the most basic services. Health systems collapse due to flight of medical personnel, shortages of medical supply, overwhelming numbers of mass casualties and attacks on medical facilities. Literally, in Yemen, bombs are dropping next to hospitals where children are treated at this very moment. Access to food, medicine, and fuel is restricted due to fighting, or, what also Ms. Beerli said, the politicization of humanitarian access by parties to a conflict. In Yemen, for example, where we work, there has been a significant increase in the number of children directly injured by the conflict or suffering from preventable diseases simply due to access on medical facilities and personnel. And attacks on medical facilities and personnel also have the consequence that people refrain from turning there. They just are scared to go to these facilities for help. Again, in Yemen, for example, we see that pregnant women are giving birth in caves rather than going to hospitals where they could have access. And due to the overwhelming amount of mass casualties, patients are referred to private medical facilities with charge for care, out-of-pocket payments being a serious burden for already vulnerable families. You can imagine what that means for families who don't have money and even have less money in war. Natural disasters and disease outbreaks can, of course, exacerbate children's exclusion from immunization, and this figure shows out of nearly 15 million children who do not receive basic immunization, 2/3 live in conflict-affected areas. Among these, South Sudan has the highest level of children not immunized, 69%, you can see that, followed by Syria, and then Somalia with 58%. We know from our work on the ground that rising levels of malnutrition caused by war and terror result in reduced immune systems and increased risk of pneumonia and diarrheal disease. Malnourished children are 3 times more likely to die from diarrheal disease, which is even more tragic because usually you can cure diarrhea very easily. And diarrheal disease are themselves a cause of malnutrition. So we are in a vicious cycle. The example of Yemen again shows that how devastating the consequences can be. The country is not only on the brink of a famine, as my colleagues already said that referred to Yemen, it is in the midst of it, and more than 3 million children and pregnant or lactating women suffer from acute malnutrition at this very moment. But as I said in the beginning, war and terror not only impact children's physical health and well-being, but, and this is very dear to my and our work at Save the Children, it impacts their mental health and long-term development for years and probably decades to come. In Syria, at least 3 million children are estimated to be living in areas with high exposure to explosive weapons, while 84% of adults and almost all children consulted for a Save the Children study report, for example, that ongoing bombing and shelling is the #1 cause of stress in children's daily lives. 80% in this study we conducted recently, 80% said children and adolescents have become more aggressive, and 71% said that children increasingly suffer from frequent bedwetting and involuntary urination, both common systems of what we call post-traumatic stress disorder among children, also among their families, but among children for the most. If, and that's the point, if traumatic experience like that is left untreated, it has a devastating impact on these children's future and on efforts to rebuilding a lasting and durable peace for new generations. That's also what my colleagues stressed before. I can't stress it more. What we see in Syria, and you can see it in this quote from Mohammed, a worker we work with in Idlib. What we see in Syria, Yemen, and lots of other places in the world today is, frankly, the risk of destroying the future generations that one day also need to rebuild their countries. Uneducated, emotionally destroyed, completely stressed. When I go and see what we're doing on the ground and I see in these children's eyes, I see horror, I see distress, and I don't know what we do with these kids if we don't treat them mentally. I think it's a huge risk for our world, actually, one of the biggest ones in these sections. What came through clearly in our research, however, and that's what also drives me to do this work, is that despite all they are going through, many children still dream of a better tomorrow. So this gives me hope, and this gives other people hope to work in this field. This is why we, as Save the Children, do the work we do, and this is why we're here on this conference to urge humanitarian agencies, donors, the wider international community, national and local authorities, and especially the health community who's sitting here, to prioritize and coordinate the physical and mental health of children and to focus the health efforts on this special subject. Ladies and gentlemen, thank you very much, and I'm happy to discuss later.
Well, thank you, Mrs. Krüger. And now talking about Syria, we have Dr. Ahmad Tarakji, who is the president of the Syrian American Medical Society. And his endeavor is, his society is to oversee the humanitarian response plan for many of the humanitarian Syrian crisis. So please welcome Dr. Tarakji.
Thank you, Madam Chairman, for hosting the panel, and thank you, everybody, for joining this session. My name is Ahmad Tarakji. I'm the president of the Syrian American Medical Society, known as SAMS. I want to make the argument today that the narrative of the war in Syria has changed the narrative of war for the upcoming century. But at the same time, also, I want to make the argument that the healthcare workers in Syria also changed the history of humanitarian response. Over the last 7 years, the suffering and trauma that we endured in Syria and in the region is really unprecedented, and there are no one particular number to reflect the suffering that we went through. My colleagues in SAMS over the last 7 years, they endured chemical weapons, direct targeting, lack of resources, lack of recognition of their work. Yet, we were able to establish about 200 medical facilities inside Syria and the neighboring countries. We had about 2,000 healthcare professionals, physicians and nurses, surgeons, who are providing care. And last year, we were able to provide 3 million medical services in Syria and in the region. About 2.5 million of them are inside Syria. And as we talk about stability and resilience of community, the goal that we set for ourselves is not only to respond to a crisis, but also at the same time plan for the future. And that led for us to change the approach after 2 years, where about 2/3 of our programs are focused on women and children. and we feel that approach will stabilize the communities. There are many stories to be told. I'm going to focus on about like 4 topics that will reflect, again, the narrative of changing the concept of war for the next century and the concept of humanitarian response. A few months back, we joined with the Lancet Commission with Harvard, Hopkins, and the American University of Beirut, and we went over the experience over the last 6 years. And we've used the term of weaponization of healthcare in Syria, where the state itself, utilizing what's supposed to be sovereignty of the state, where attacked healthcare and abandoned people from having access to healthcare. And therefore, I mean, that's obviously well-documented story. But at the same time, to my personal shock, it's actually not different from the pattern that was used by ISIS, Al-Qaeda, and others. And you can see at this time that the community is suffering from everybody around it. Myself going to medical school, I graduated 20 years ago. I did not learn in any book how to respond to the humanitarian crisis caused by ISIS or Qaeda or a government. And certainly the learning experience is painful, yet it means a lot. So I want to start by the axis, what we have been talking about, the axis. And this is the early report that we've used about besiegement. That goes back to 2013. And back then, the concept in Syria that, every single community will be punished by abandoning and blocking their access to medical supplies. They can get blankets and lice shampoos and maybe some other supplies, but not medicine. And that story continued for the next 4 or 5 years, very well documented and very well published, to the point where the UN leadership start talking about it. Obviously at a different pace, as the healthcare workers on the ground were talking about it early enough. So this is from our report back in 2013. At that time, we estimated that more than 600,000 people are besieged, completely blocked. And yet there's definition at the UN and so on. And you can see I'm looking at the discrepancy over here of what's the definition of a problem. At that time, our colleagues in UN OCHA, their estimation that the besiegement was affecting only 200,000 people. That's reflected over there. And the concept is not to say who's doing more and who's doing less, but the actual humanitarian response structure will not work well in the presence of weaponization of healthcare, where the healthcare sector is being attacked when the state is the one who's doing the targeting. And in Syria, for example, this number went up from 600,000 to 1 million plus, and more than 90% was done or inflicted by the state itself. That's different from the traditional culture of a war where the non-government groups will be the source of terror and undermining of stability of civil society. And that's the exact problem that we're facing in Syria. By the way, that is still going on right now. So in the suburbs of Ghouta right now, there are about 400,000 people who are completely blocked off of any resources. And in the past, they've been getting some stuff through smuggling with the tunnels underground and all of that. But then about 5 kilometers out of that town, the price of food is only 10% of the price of the food that they have. We conducted a study looking at people who have renal failure, who are on dialysis. And we showed that for patients who are in renal failure, this is out of the government-controlled areas. So this is people who are supposed to be affected equally. So for people who are out of the government-controlled area and not under siege, the mortality rate is half of the mortality of the people who have renal failure on dialysis in besieged areas. Just give you a concept of what's there. But even more than that, This is back in 2015. We had this report also that we published with our colleagues in Physicians with Human Rights, where we've seen people being starved to death, live. In this century, none of us have imagined that we will see this death happening in front of us. And for many months before that, we were out and loud that there's besiegement, that these people have no food. And you can hear some response and people resonating with that, plus minus, believing, not believing, whatever you want to call it, to the point where people start dying. In this town of Madaya, there were about 40,000 people who were completely besieged. And there was only one hospital, that was our hospital, and we had 5 doctors in it. And we're documenting every single death, live. So there was what's supposed to be an intervention from the UN, the UN Security Council. They have reports and they published something to condemn that. It took about like 3 months to have a reaction, a meaningful reaction. From the time of the condemning and asking for intervention till the time of something happened that's meaningful, we had about 60 people dying. This is just, everybody's watching that. Moving on to the next experience that unfortunately we had to suffer is the ongoing chemical attacks. And I think most of us are familiar with the attacks that took place in 2013, where about 1,500 people died right away from using nerve gas. And people who follow politics, they're familiar with the red line that was opposed by the US administration back then. So when these attacks were taking place and so on, then there was the action of what looked like dismantling the Syrian regime from the chemical weapons. And gradually, I mean, if you look at the details, unfortunately we have to learn that because nobody was doing this. So you would think that documentation of chemical attacks should be done by experts. With lack of access, then physicians have to train to build a preparedness plan to minimize the damage of those chemical attacks, do legal documentations, share it with the investigating UN agencies, and have those reports out. And certainly you can look at time, you can look at the time frame and the gap that existed between where the civil society is responding and where the international agencies are. But we made the argument early on from 2013 that those attacks did not stop. And what happened is that the style has changed. So instead of using nerve gas, chlorine was being used, which is by definition, if it's used for mass killing, it is a chemical weapon. But that took about more than a year plus to get recognized. You would never believe that's happening right now, but it is happening, that to recognize that chlorine is a chemical weapon took about a year and a half after the chemical attack that took place in 2013 with the Syrian, with the nerve gas. So we did our report where we look at the attacks, and you can see from the second line over there where there was an increase by 77% of chemical attacks after the UN Security Council resolution 2118 that's related to the chemical weapons. And even after that, we made the strong argument that some of those attacks are atypical for chlorine, and we raised the suspicion that there's something else mixed with it, till the recent chemical attack that took place in Khan Sheikhoun, where at that time we had enough documentation to say that this was nerve gas. And then you saw the international community response to that, confirming this information. So you can see where this is just dragging along. But at the same time, we're talking about the humanitarian response. Those people on the ground, my colleagues, not that they did not have enough medications to respond to that. There's no protection gears that they can wear. So many of those physicians were affected firsthand as they're trying to treat people. And the third time, they were faced with what's more painful, which is unrecognition or lack of recognition of these attacks. they're not willing, or they don't care if their names are up and they're recognized for their work. They believe in this value of serving the community. But the problem is that huge gap where exactly the state terrorized its people by blocking any access to it. And with that, most of the international agencies would not take the risk to go inside and assess the situation. So now you have black hole where nobody knows what's going on. So we are left in a position to build that chemical preparedness plan, which is a job that should be done by a state, set the contamination centers, train people how to respond to chemical attacks, and train actually communities how to recognize chemical attack and what to do when this is happening. But moving on to what I think is the flagship of the Syrian crisis, which is the direct targeting of hospitals. So in Syria, the barrel bombs and the smart missiles and chemical weapons, as a matter of fact, they don't drop near the hospital. They drop on the hospital itself. And we've shown the pattern of those attacks, that it's not a collateral damage. And as everything else in Syria, this is a task that the physicians took on themselves to train, to be able to document these attacks with the details that are needed and report them frequently and share them with the international community. And you would think that when you get the first, second, or 100 attack on a hospital, then there'll be this outrage from the community, international community. And there was dead silence. And you can see the change of the pattern, how things have changed. There's always this argument that when I go to Geneva or New York by some states, they ask me a few questions that I feel if I was the foreign minister of that diplomat, I would fire him really, because his quality of argument is bad. But the point is, they always ask you this question, like, how do you know those were hospitals? So the international humanitarian law actually is very clear about that, about what is a hospital and what's not, and when you cannot attack a hospital. And on top of that, actually, most of these are hospitals or were hospitals before the war in Syria. So they are well-recognized entities even before the war. But on top of that, not knowing, looking at the pattern of those attacks, and you can see there are a few hospitals in certain areas that they got attacked more than like 60 times over the last 6 years in that block. And most of those hospitals, at least I would say on behalf of my organization, we're away from the front line. So we're not anywhere where there are clashes. And as a matter of fact, we offered to the international community to share the location of the hospitals and live streaming from the hospital so everybody's comfortable that it is a hospital and civil structure. But nobody was interested because they don't want to own the problem. So this ongoing conflicts and attacks and so on, we had to change the plan of how to provide health in those towns. Because, and unfortunately, I've seen it as I'm leading the organization over the last 3+ years, the minute that the healthcare system collapses in a town, the town will surrender and they will just leave. They will go somewhere else. That's in every single town. If people are familiar in Syria, it happened in Madaya, it happened in Aleppo, it happened in Homs, it happened in suburban Damascus. Every single town. The last thing that if they want people to get displaced, they besiege them, they do everything. The minute that the healthcare sector collapses, that's when they say, we're done, we can't do anything, and people leave. So with that concept, we always thought that, and we were with our colleagues and from other international organizations, we actually lobbied really hard to have the UN Security Council state what should be the obvious, which is the resolution of 2286, which is talking about protection of healthcare facilities and the task of respecting healthcare services. Now, you would think the resolution should be stronger than that. but then even the way it was built, it was very weak. Regardless of that, but this happened actually many years into the conflict in Syria. Now, for observers from outside, you would think this is just second nature, that there is actually laws and there's the concept that you should not attack hospitals. So if I'm telling you 4 years after or within the conflict that you should not attack hospitals, then there is a problem. And this is the current state of the international humanitarian law, where we all talk about it and love it or so on, but actually it doesn't exist. It's not in practice, at least in the context of Syria. And that's why I was making this argument that the war in Syria changed the whole approach of the narrative of war. And as we kept talking about it, and people from inside even said the same thing, like, don't worry about Syria, we know we're not going to do anything for it. But when we did the math for attacks on healthcare facilities and healthcare workers across the globe, we noticed an increase by 50% over the last 2 years, because the warlords are learning right now that you can get by doing anything you want as long as you can play politics correctly. So we saw that surge in attacks on healthcare facilities. Certainly nothing to the extent of Syria. So going back to how we changed the concept, we did a few techniques to redesign the healthcare system. So we did what we call mobile clinics, where we had people stay in their houses and doctors will go to them, will do the blood pressure, will do diabetes medications, etc. Then we set certain small units where you go if you have, let's say, like upper respiratory infection, like mild disease, where you don't need to be in the hospital. And we limited the need for you to be in the hospital to very, very, very hard situations where you cannot be treated anywhere else, like intensive care units or something of that sort. And that's where we had to focus our hospitals. And for safety, actually, we moved the patients who are undergoing surgeries in intensive care situations to underground. So at least your chance, if there's an attack on a hospital, because you can't run away, obviously, if you're under anesthesia or you're in an intensive care unit on a ventilator, you're not going to be able to run away. So you need to be the most protected. And unfortunately, the guys on the upper floors will take their own chance. That's why we don't move them out. With that change, actually, we improved the safety of the patients and physicians. But going back to the initial concept that I presented, like in people who know the narrative of Syria, or I bring the narrative of Aleppo, the city of Aleppo, which is where I was born. And in the part of the city of Aleppo, at the peak of the attacks, when there were attacks every single day on the healthcare sector, that's before the collapse, complete collapse, even at that time, the number of patients who needed trauma surgery or trauma care is still less than the number of children who needed routine care in these facilities. So the week before Aleppo collapsed, for example, in our facilities that are there, we had like 7 facilities. I still remember the number. The traumas were close to about like 1,900, and the children were close to 2,200 for that month. That gives you a reflection of how collapsing the community is. I'm running out of time, I guess. But so what we did, one thing that we wrote a report about is we went back like many centuries behind, where we went into caves. So we moved the hospitals underground, we moved them into caves, and this is one of the hospitals there. We built about like 5 hospitals in the caves, and we moved about 22 facilities to underground. And we had certain patterns of how to do it, which is, well, it's complicated, but we published that. Maybe it was a mistake.
Tarakji, may I ask that you conclude?
Yes,
so
absolutely,
we'll have
yes, absolutely.
time for discussion.
Absolutely. So as we did those underground hospitals, we had this great warning system. Our dogs outside, they would let us know what's going on. And towards the end is, I just want to move fast here as we're talking about coordination. And just if you give me like 1 minute on that, please. So after about like 6 years, and we've been very critical of the performance of the international agencies and the coordination that's being in Syria, and I know that they were getting lots of pressure from the government and other political parties, we reached the point where we're putting our vision on that, and it hasn't been working. So we said, well, you know, we will continue to do our work by providing care, but we will not be able to collaborate with the UN agencies unless you change your style. And at that time, I called to every single principal office that this is not the right step, yet we committed to it. At that time, 73 organizations that works with Syria took the exact same stand. At that time, after about like 2 months from that, we did the working paper. We had 13 points, and the UN agencies approved 12 of them and changed their style that way. with that, and that's the importance of being loud and clear, still the Secretary General Ban Ki-moon came to our event at the World Health Summit, World Humanitarian Summit, and we've talked about it, and he was very appreciative of us being upfront and clear about that, because all of us, regardless of our style, we want to make sure things are better. So that's the only message I have at this time. Thank you.
Thank you, Dr. Tarakji. I want to commend the audience for being so attentive to all of our speakers. In interest of time, we will take questions from the audience, so you can be not so quiet, and all of your questions are welcome. If I see no hands, yes, please go ahead, and then over here. Please introduce yourself to the speakers.
Yeah, thank you very much, and a very good morning. My name is Volker Westerbarger. I'm the president of Médecins Sans Frontières here in Germany. And first of all, I want to really thank you for highlighting what war does to people, special groups of people in this world. I think it's very necessary to remind us and others again and again about the terrible consequences. But I think if I look at the title of the session, we have not completely fulfilled the task. I mean, the question was also what's special on the war on terror and the consequences on health. And I think there's quite some differences what this war on terror does to health compared to other wars. Dr. Tarakji mentioned that, and Ms. Beerli as well, but I really want to highlight the differences, and I think that's what we need to talk about. One is the criminalization of aid. So we also had health workers from the UK who were not allowed to work in ISIS areas because this was against anti-terrorist law in the UK. And we're not allowed to help refugees in many places of the world because they are considered possible terrorists. I know it's difficult enough to take care of refugees, but it gets more and more difficult because they are considered terrorists. And that's what changes the paradigm. There's no access to people in need. If we talk about Syria again, we cannot help people in Syria because we're not allowed to cross the border from Jordan. We're not allowed to drive a single truck from Turkey into Syria because the war on terror says this is all possible support of terrorism. And that's the last thing, and you mentioned that several times, the direct attacks on medical facilities. Syria, Afghanistan, you know the story about our hospital. These are not uncontrollable non-state armed actors. These are countries which are sitting in the UN Security Council, right? They are responsible to ensure that medical facilities are not attacked. Obviously this happens, and we have tried to speak out, all of us. We have reached very little, achieved very little. So my question actually would be to myself, to our organization, but also to you, and especially to the WHO, if I can ask, why haven't we achieved anything so far in stopping the world from ignoring the human right of health, from stopping to ignore international humanitarian law? And what else could we do? On WHO level, ICR level, ourselves, also smaller NGOs working in these areas, what can we do to change the special impact of war and terror, which is so different to war we have seen so far? Thank you.
Please, Dr. Moeti and Mrs. Beerli, you want to?
Thank you very much for that very difficult question, I think. I mean, I guess these situations which are worsening and newly evolving, in a way, I mean, you are asking over the years, why haven't we succeeded? I think what we are seeing are new manifestations of this ignoring of the human rights aspects of health in the context of war. And I think you rightly say that all of this is happening in member states where, in theory, within the multilateral sphere, we should be able to influence each other. Countries, at least member states, should be able to influence each other so that these rules are obeyed. I think the reality that we know is that in multilateral fora, there are limits to what can be achieved in terms of implementing international law. In fact, that is a fact, I believe. And so what can collectively the health actors, the health sectors do to put additional pressure, to provide the evidence, to advocate, to identify perhaps those member states that have more influence than others in these fora, because I think we have to acknowledge that even if in the multilateral process every country has a vote, the level of influence of different countries is very different in these mechanisms. So I think this is where we need to be looking at alliances, providing evidence, advocacy, different actors, different constituencies, carrying out the kind of advocacy, placing pressure where it matters, including in our own countries, to influence what then the member states do when the decision-making takes place in these fora, like at the UN General Assembly, other fora in the UN. I think this is what needs to be done. I think as a technical agency, as WHO, we need to clearly engage in this further than being the coordinator of the health cluster and ensuring that healthcare is being provided. And WHO is becoming more and more vocal, at least in recognizing and expressing our concern about some of these events. I think the need is clearly there to engage with others and try to see how collectively our voice can make a difference, both at the international level and I think very much within individual countries to influence some of this. Thank you.
I think the most important thing is not to resign. Your organization, our organization, we are working very close to each other also in the field, and I think it's extremely important to uphold our principled approach, to put really the human being in the center of all of what we are doing, to very clearly also always put emphasis on the law and on the neutral, impartial humanitarian approach. And this approach, of course, as you said, and as I also read your interview today in the Berlin Zeitung, of course needs that we have a contact with all parties of the conflict, and we have to fight, and we have to also explain it over and over again to our partners in governments that we need to have a contact also to the non-state armed groups, that we need to speak with everybody because this is the only way that we get access to the people in need. And in a certain way, it's also our own life insurance for our people working with ourselves. And so I know that it's getting extremely difficult. And it's also, we have, in a certain sense, we have a strong body of law, and we still have to defend that body of law, but the gap to the reality is getting bigger and bigger, and we have to really speak with all the people who can influence what is going on in the field, that we bring this gap together.
Mrs. Krüger and then Mr. Melesse. Just go ahead.
It's working. I think it's such an important question. Thank you. And I want to just echo a bit of that and maybe say a couple of other sentences. You said criminalization of aid, refugees are considered terrorists, medical facilities are being attacked. Yes. But you know what? The whole humanitarian principles are under attack since years and years and years. I mean, what guides us in our work, like impartiality, neutrality, independence, like Henri Dunant, you know, this is like values that I, like, this is why I work in this field. And I think we have to speak up for them, and we don't do that anymore. We speak about, like, on the Mediterranean, we speak about that we are the criminals now who are smuggling terrorists into the country. We are humanitarian organizations. We should stand up for that. So I think this is what we can do. Like, we have a body of international law that is, like, I mean, people are not behind that anymore. But we have, like, after the Second World War, there was a reason for that, and we have to stand up for this. And I think this is something I would really like that this audience, like, gets away with or gets home with, you know.
Mr. Melesse? And then we'll take another question. Just go ahead, speak in the microphone. They're all
okay. Thank you. Well, I think here a very interesting question, but for me, the fundamental question is today's war has to be redefined. In the previous times, it was either between the states or opposition and government. Today they tell you it is a terrorist war, but we don't know who the terrorist is, because the war is interstates. Those who are saying it is terrorist, they are themselves the ones who are supporting the terrorists. Nobody recognizes the government. The definition of war, what is the nature of the conflict? That's where it's becoming complicated. You don't have an opposition group with whom you can negotiate. There is no, on the other side, take the Syria case, how many players are there? Why don't they come out straight to the table and say, we discuss with that? This is the states which are involved. I think that the second important thing is the refugee situation. There should be a different kind of thing, because the implication beyond the rhetoric is, look at the election result in Austria, German elections here, what's going to be coming the next election. I think there is a need, the fear, politicians playing with the fear of what is happening, the terrorist attacks and so on. There is a need to redefining and really repositioning ourselves. We can't move on to do the conventional definition of the things. Some things have to come to the table. I don't have the answer. Thank you.
Another question from the audience? Yes, up there. It may well be the last question, if there are many answers.
Thank you. My name is Sam Lowenberg. I'm a journalist, write for The Lancet and other publications. I'm currently looking at the various severe hunger crises that are happening around the world, in Yemen, South Sudan, Nigeria, Somalia, and Ethiopia. And the interesting thing, or one quite interesting thing there, is that in all of those cases there's also cholera outbreaks. And I think that's quite unusual in a mass hunger crisis. Usually you see them in refugee camps after natural disasters and so on. And we know the immediate reasons for those crises, because water and sanitation facilities have been destroyed. People have been moving around, having to had their water usage disrupted and so on. But the fact that it's happening in all five at once and in all these different cases seems to me something quite new. And I wonder if the panelists could address that.
All the contexts you just mentioned are contexts where there is also conflict or violence, and this has fragilized the society, the health system very clearly, the water system. If you look at Yemen, needs fuel to make his water pumps work, and as 90% of what Yemen needs has to be imported, and almost nothing can be imported anymore. So there is no fuel for the water pumps, so then the water is dirty and cholera comes up. So it's a very clear line from fragility, conflict, water problems, food problems, and finally cholera and famine. I think this is a very clear correlation.
Thank you. I think this is a very good question. I just want to go back to the definition of war at this current era right now, where at this time it's all-out war, meaning that when there is conflict, they want to destroy everything on the other side. That includes healthcare facilities, access, and so on. So that's why you see complete collapse of any humanitarian structure. And that's where you see the cholera and other infections and lack of vaccines and all of that at the same time. And this is, you're right, that observation is very correct. As a matter of fact, it does have to do with the change of what war is being done right now as opposed to being in the past, where you're right, where there's conflict, people will get displaced and they get risk over there. But right now, they're targeting the communities where they're at. By all means, that's available for them.
Thank you. Well, I think this session has come to an end. Obviously, we would need another session to discuss how to coordinate all this. I want to thank all the panelists and the audience this morning. Thank you.